Well, welcome to this morning. My name is Dr. Phillipa Moore. I'm a consultant microbiologist at Gloucestershire Hospitals Trust, and I work with the Public Health England Primary Care Unit. So this is one of the clinical scenario sessions to talk about, firstly we're going to talk about acute rhinosinusitis. So we start with a clinical presentation. And this is for a 35-year-old non-smoker with nasal congestion and yellow nasal discharge for 10 days, mild right facial discomfort, sore throat and cough. He has previously had sinusitis and that he usually needs antibiotics to clear it up. Temperature 37.4 degrees, pulse 88, blood pressure 142/88, right-sided maxillary tenderness, mildly red throat, bilateral, mildly red tympanic membranes and no lymphadenopathy. So hopefully you can picture this patient, and if you think first of all, what would you do for this patient if he was in front of you in your surgery? Have a think for yourselves. When you come to present this to your surgery, you need to get everybody to think, would you prescribe antibiotics? What would you do for this patient? Okay, so lots of you would have very different ideas on this. And there is Public Health England antibiotic prescribing implementation tool, which gives some advice on what to do with sinusitis. So the management options are to continue with self-care with just paracetamol or ibuprofen. There's little evidence that nasal saline or decongestants help. Obviously they get promoted on the television, but actually there's not a lot of evidence behind them. But people may wish to try them. There's no evidence to support the use of oral decongestants or antihistamines, mucolytics or steam inhalation. The patient could consider taking high-dose nasal corticosteroids for 14 days in adults and children over 12 years. There's some suggestion on that. Or you could consider antibiotics or delayed antibiotics for mild to moderate symptoms. But antibiotics make very little difference to symptom duration, which is usually obviously what the patient is interested in. Immediate antibiotics should be offered to those who are systemically unwell, have symptoms and signs of a more serious illness, or at high risk of complications. And consider referral to hospital if there's evidence of sepsis, such as intraorbital complications, periorbital cellulitis, this sort of thing. So in the discussion about how to manage the patient, it's important to refer to the Public Health England prescribing implementation tool. That contains information on, for example, if symptoms are less than 10 days, do not offer antibiotics. It suggests when backup antibiotics, so a delayed prescription might be useful. And it's worth pointing out to people that by clicking on the links in the guidance, they can get an awful lot more of the evidence that's behind the guidance. There are also obviously antibiotic prescription doses and durations to be given if it's appropriate. But what we're really wanting people to do is to think, actually, are antibiotics needed? If they are needed, can they be delayed and only started if the patient is sure that they're needed? We're trying to reduce overall prescribing. So the NICE guidance and the PHE guidance has a clinical scenario on what to do with sinusitis and antimicrobial prescribing. Basically, first question, are the symptoms there for 10 days or less? If yes, then do not offer an antibiotic. If no, then the question is, are the symptoms improving? And as you can see, that there's an algorithm to follow as to whether people should or should not give antibiotics, should or should not consider giving antibiotics. And this could change if the patient scenario is a little bit different. Think, what if the patient was 80 years old? Would that influence what you're thinking? And it's worth having the discussion in the surgery as to what patients would you think of in terms of definitely not giving them antibiotics, or really actually they should be given antibiotics. Can you think of individual patients, for that matter, that come to see you? And obviously there are some patients who demand antibiotics that much more, and that has to be taken into account, that you really need to educate those patients about the value of not giving antibiotics when they're not needed. So what we're saying here is to consider self-care, high-dose nasal corticosteroids. The antibiotics really make very little difference to the symptom duration. Consider antibiotic or delayed antibiotic for mild to moderate symptoms, and immediate antibiotics for those who are systemically unwell or have complications. And obviously the complications are defined as to what would be a serious complication warranting immediate antibiotics. Consider referral to hospital if necessary, and it's always good to give the patient information. So the Target website does have patient information leaflets, which you can download and print and give to the patients. So it's always worth pointing that out to people in the practice. So on the Target website, there are posters available for your surgeries. These can be printed, they're free, and they're quite colourful, and they are for patients. They're providing information about why patients should not take antibiotics when antibiotics are not needed. There are also videos, again, with the same sort of information. I think there's increasing awareness among patients that antibiotics should not be taken when they're not needed, and there is a downside to taking antibiotics when they're not needed. These health promotion messages reinforce that. There are also patient information leaflets that are available, and again, they're free, they're downloadable from the Target website. There's also patient information leaflets about not prescribing. So these leaflets have been developed with a number of different partners. Again, they're free, downloadable, and they can actually be accessed via EMIS or System 1 if you put into the read code, which you can see in your packs. You might want to consider in your surgeries whether you have a stack of these pre-printed, otherwise they could be printed out during a consultation. They can be personalised, as you can see. They've got sections on what sort of infection the patient has, what to expect for the patient in terms of what the duration of symptoms is likely to be, advice on self-care, safety netting advice on when to get help, as well as when to attend the surgery to get up a backup prescription. And obviously you will have had that discussion about backup prescriptions with the patient. And so if you make everyone in your surgery aware of these can be used as part of the consultation and as a way of educating patients so that they don't expect antibiotics and so that they're not coming back and demanding antibiotics. Important that where delayed prescriptions are given, that there is a read code for delayed prescriptions. And again, these are all available on the Target website as well. So if you think about this particular scenario of acute rhinosinusitis, then what else could your practice do this year? The Target website has audit tools for a number of different infection scenarios. You can see that acute rhinosinusitis is one of them. The audit tool is there for you to use, so you don't have to develop it. And so you might think about, in your practice, what's most important. Would acute rhinosinusitis be a good topic to look at in your practice this year? So what might you do in the next 12 months? And I think it's worth going away from here, and when you go back to your practices, to sit down and think about writing an action plan for the year. What can you do to promote the use of local antimicrobial or the PHE summary tables in your practice? Is everybody even aware that they exist? Does everybody use them? How can you access them easily? Are they on the desktop of your computer? Encourage the use of the Target website. There's so much information on there, so many useful tools, and it would be good for your practice to be aware of just what is there for you. The treatment leaflets, the no prescribing leaflets, and it's really important that there's a consistent message across the practice to patients, so that obviously patients, when they come in, are more likely to get antibiotics from one prescriber than another. Audit always helps in terms of for prescribing. So it's useful to audit and re-audit to prove that, and again to be part of a work plan for the surgery. So that's something you'd want to go away and work with your partners with for that. And then record your actions. And especially if you've got low compliance with prescribing, then you might want to think about what's that about, what education may be needed. There are also education tools on the Target website, and so it would be worth looking at those, particularly if there are some areas where the prescribing is not what it should be. And you might even want to consider developing a target within your practice for what the antibiotic prescribing rate should be. Okay, are there any questions?